everyone. My name is Vanessa and I'm very honoured to welcome you all tonight to the Where Do You Aim at the Geelong Library and Heritage Centre, and I am the CEO of the Geelong Regional Library Corporation. Thank you very much for being here. I'd like to begin by acknowledging the Wadawurrung people of the Kulin Nation and the Gullah-Jan and Gadibanurra peoples of the Maar Nations as the original owners of the lands on which our library services operate. I pay respect to their elders past, present and emerging, and I acknowledge and celebrate First Nations people of this land as the custodians of learning, literacy, knowledge and story. And today, of course, we are on Wadawurrung land. And I'd also just like to acknowledge any First Nations people here in the room today. So, welcome, You Talk, We Die, a story of community activism. Tonight, our discussion will focus on the issue of drug addiction and how every region, every community in Australia is impacted by this, and Geelong region is no different. And we'll consider how we as a community can help to save lives in the region. Author and community activist Judy Ryan was heavily involved in the establishment of Victoria's first safe injecting facility in Richmond, and her book, You Talk, We Die, is the story of a grassroots community campaign that really made a difference in Melbourne. After raising her family in regional Victoria, Judy relocated to inner city Melbourne in 2012 and became immersed in Melbourne's deadly heroin crisis, and in 2016 launched what ultimately became a successful residents' campaign for a supervised injecting facility in Richmond, as you know. Judy was awarded an Order of Australia in the General Division in the 2022 Queen's Birthday Honours List for service to community health in a range of programs. And Judy has just been announced as a Sir William Kilpatrick Churchill Fellowship recipient. Congratulations. And of course this will involve travel overseas next year to learn how drug-impacted communities engage governments to save lives using health-based solutions. And joining Judy on the panel tonight is Dr. Mark Davis, Lara Medical Group's GP of General Health and Drug Addictions, Craig Harvey, researcher and harm reduction practitioner, and the discussion will be facilitated by Dr. Tim Denton, who is a semi-retired GP at Cardinia Health and of course was one of our local GPs down on the Surf Coast for many years, so it's lovely to have you here again, Tim. And Tim has worked in alcohol and drug service delivery for the last 7 years. Our panellists tonight will share their wealth of knowledge on this critical community health topic, and I'm very much looking forward to this discussion. Over to you, Tim.
So I was going to do a whole pile of CVs, but I won't believe them. Now I will continue because Mark and Craig have both have come to this country from the old art. And Mark qualified as a doctor in London and worked as a GP in the Geelong region and has done so for the last 30 years. And he's worked in the drug and alcohol field largely by accident, as pretty much I was, but loved working with clients which he met, which made a big difference. Over the past 28 years he's been working in opioid replacement therapy, and more recently he's worked with the Salvation Army Detox Unit out of Corio. And he feels it's important, the most important message he can pass on to our junior workers is listening to the people in front of you, just listen. You might have heard that message. The last few words. With regard to Craig, Craig's a board member of the Harm Reduction Unit in Victoria, and he's worked in the field of harm reduction since the late 1990s, starting his career in Birmingham in the UK. Craig's developed an innovative programs which address the health disparity and rights of people that use drugs, and this includes the development of opioid pharmacotherapy programs for men that sell sex to other men, crack cocaine programs, and programs which address enduring homelessness. Since migrating to Australia in the early 2000s, Craig's had a number of roles, and one of which was working at the North Richmond Community Health Centre, which is very close to where Judy's been working. prior to the introduction of the medical safe injecting facility. And Craig has held a role of mobile overdose response worker and has first-hand experience in attending countless overdoses. And Craig's current role sees him overseeing overdose prevention programs, safer injecting programs, and needle exchange programs. Good. So what we're going to do is just run a few questions. They're fairly, before we throw to the audience, they're fairly general terms, but and we'll all join in. Well, I won't. You guys will all join in when you feel it's necessary. So the first question is to you, Judy, and it's a really broad question. What did you learn the most from your long campaign to establish the North Richmond Safe Injecting Facility?
Thank you, Tim, and welcome to everybody. Thank you for your interest. Look, I could talk for hours about this, and I won't because I've written a book about it, which is why I did the book, and it was COVID. But basically, there are a handful of things that really struck me. And when I moved back to Melbourne from living in Wodonga and with my husband John, who's got the white cap on down the back, he's my bookseller. So we moved back to Richmond knowing very well that it was a heroin using area. So it wasn't like I moved in there and thought, oh my God, there are drugs here. I did know that. However, for the 4 years that we were there from 2012 to 2016, I just couldn't believe how bad it was, how shocking from a human perspective. And one of the things, of course, for years, drug addiction is considered a criminal issue. And it was quite clear to me, and I'm not a medical person at all, but speaking to people who are using drugs in my laneway and people that I ran into around the place, it was a clear health issue. From, can you tell me your story? Are you able to tell me your story? And the backstory to them using the drugs was pretty shocking. Trauma, child sexual abuse, injuries, lots of things that had happened. And so I formed this idea in my very non-medical mind that this is really bad. We're having, police are picking these people up. They're ending up in the charged into court system in jail and back in my laneway. And it just was madness. And as a taxpayer, I resent that we're building jails with a big sign, Barwon prisons, on the road down here. Well, how good would it be if it was Barwon rehab centres and support services for people with addiction? That would be great. Anyway, after 4 years, I had an experience one day, and it is in the book, so I won't go into it too much, but I was coming home, it was a Sunday, and I found a young man overdosed at my back door, and I did recognise him because you do get to know the regulars. And it just triggered me. I thought, I've had enough of this. This is just insane. And the classic line, they should do something about this. And, I rang 000 and the young man survived. But I said to John, this is just crazy, they should be doing something about it. And he said, who's they? And it's a great response, but I was pretty angry and upset and I'd had enough and I just really thought this was madness. So, without going too much into it, you asked me what some of the issues were. Firstly, did anybody else care about this like I did? I'd only lived there for 4 years at that time. So did my neighbours think about this? Did they care about it? Because you can never do this on your own. And so life intervenes, and 3 months later there were local council elections in Victoria, and I ran in the City of Yarra council election as an independent on the single issue of a medically supervised injecting and trial in North Richmond. Now, I didn't want to get onto council, I just wanted to do market research. Did anyone care? And I really believed I'd get about 34 votes. And I polled really well, 4.6% of the primary vote, which was great because I got my candidate's feedback, and because I was a volunteer and I was paying for all this stuff on my own, it was great. But it was the preferencing that really worked. So people, after they'd voted for their rusted on, Greens, Labor, Liberal, not too many Liberals in Yarra, but Labor or Greens, they gave me their second vote, an unknown person on a pretty tricky issue. So it was, so I didn't get onto council, but it gave me a mandate for action. But then what to do? we'd had, and I looked at the research, and Steve Bracks tried to get 5 up in 2000 after he was voted in, and that got nowhere. Great idea, got David Penington on board, all the research, but no, it was all blocked in the upper house, and that was 16 years before I turned up to do what I was doing. So what do you do? You know, but getting people together, and I think and why I'm here tonight, I'm not a medical person, but I'm here as a community activist, and I just want to share very briefly the fact that there's no cavalry coming over the hill to save us here. Governments are pretty reticent to get involved in anything that could look ugly or difficult, or they'll get hammered in the press, which is supervised injecting rooms are that. They're absolutely that, and that's why governments are pretty disinclined to get involved. Fascinatingly though, when we got the ball rolling in Richmond, because Dan Andrews was saying no to this, we're not having one. I didn't go to the last election with this as a policy. The Herald Sun were all over me. They couldn't get enough of what was going on in Richmond, photos of the topless tap street where people were using the water in people's gardens to mix up their drugs to inject, and when they got home somebody would be overdosing their garden and the tap would be running. And the journalists loved it, and they brought their photographers out, and I'd say, why don't you guys come down and have a look what's happening next to the school? You know, you've all heard about the school. Well, no one was interested in the school. They all wanted to go to the topless tap street. And what was happening next to the school was a car park upon which people would get their drugs in Victoria Street, come to where Craig was working with the needle syringe program at North Richmond Community Health Centre, which is right next to the school. They'd get their needles and they'd inject on the car park next to the school. And there'd be ambulances and there'd be code blues from the Community Health Centre. It was chaos. But no one was interested in the school, what was happening at the school.
So, Judy, how hard was it to actually get this final?
It was hugely hard.
What sort of strategy did you use to achieve that?
Well, we had to educate our community because a lot of people knew a supervised injecting room sounded like a good idea, like I did, and I took myself up to Sydney to have a look at what that was like, and they were very supportive, gave us material to use. But we had monthly forums where we invited all the community to come and speak to us. We'd get a guest speaker, a doctor or an ANBO or a local police officer or somebody from the media to come and talk to us each month about a particular point of interest. But Tim, it was hard. It was really a lot of time and it was a hard slog.
How many years did that?
Well, it really only took 12 months from the time we started campaigning with the City of Yarra to Dan Andrews announcing it. And politics did kick in, there's no doubt about it, which it always does. And sometimes it happens when you least expect it. But as a community activist, you have to be ready for any opportunity that might come up that you can make the most of it. And I know Richard Di Natale is here. Hi, Richard. And there was what happened very briefly, the Labor member for Northcote died very suddenly from breast cancer, and there was a by-election in that seat, and the Greens were standing against Labor, and Labor wanted to keep it, and they lost it to Lydia Thorpe, as it turned out. Now, but they announced the injecting room before that, just before that election happened, and even though the Greens won it, and people said Dan Andrews made the announcement to win back the seat, but I don't think he would have announced it without our work. There's no way governments are going to do that without the support of the community, and we proved that through the election in Yarra and the work that we were doing, and we ran a great big rally in Victoria Street in Richmond on a freezing cold day, and we had people coming out of the woodwork. But it's hard. It is not a pushover.
So the question now to Mark.
The question now to Mark is, in your view, why do people use drugs? I mean, we have to take it back to that basic question.
Okay, is this just not on?
Well, maybe it is.
Is that on now?
Yeah.
So I suspect we're talking to a very well-informed audience here, so I won't bore you for ages. But just just to say there's a very wide range of drug using, obviously. So the vast majority of people use drugs for pleasure and occasionally and well within control. But if you look at the group of people that really get into trouble with it, and I guess are injecting harder drugs a lot, most of them have a history of some sort of difficulties in their life. So if you look at a typical methadone clinic, we know that 80% of the clients using methadone or buprenorphine will have one or more psychiatric diagnoses, and the range goes from schizophrenia to bipolar disorder, so very serious mental illnesses, to traumatic upbringings, and the traumatic upbringings can be sexual abuse, physical abuse, or just mental abuse, which can be just as little as neglect, but feeling unloved. And often what we find is drugs actually help the person deal with the reality of their life and that pain. And I always think that if you give Joe or Josephine average some heroin, they'd probably go, oh, that was very nice, great. Okay, I've got to go to work on Monday, or I've got to go and look after the family. But then some people, you give it to them and they go, oh, now I'm not thinking about Uncle Jack touching me for the first time, or I'm not thinking about my severe anxiety or OCD. So there's a wide range of reasons why people use drugs. So I think I love Judy's comment where, you know, what are we doing with the police picking these people up? I mean, it just seems that we've got to this point in our society where it's illegal and we're just punishing more and more people for nothing. And it's well worth thinking about some really good examples, Switzerland and Portugal. So Portugal, to me, has always been fascinating because in about 2000, they made all drugs non-criminal. So they stopped locking people up and giving them sentences for using drugs and having small amounts of drugs on them. And Portugal in Europe used to have one of the highest rates of locking up people in Europe, and they went from one of the highest to probably the lowest within something like 2 years. The numbers are climbing, but they're climbing in the whole of Europe. And it is interesting when we look at Europe, and so the average seems to be about 22 people in jail per 10,000 people. Portugal was high at about 17 and has now dropped down to about 9, and 40% of people in jail in Portugal are there for drug offences, and now it's down to 15%. So if you think most of Europe, you know, 12, 13, Britain a bit higher, sorry Craig, about 17, Australia, on average 70 people per 10,000. So we lock up, you know, 2 to 3 times what anybody else in Europe does. And then you go to the United States, where they have a completely draconian approach to life, you know, the pain of life. They lock up 1,000 people per 10,000. So 1 in 100 people in America is in jail in a private jail system. So that's well worth saying as well.
And sorry, Craig, have you got some thoughts on that?
About the incarceration of
No, just I think we've established that. Just, you know, why do people use drugs? Have you got anything?
Yeah, I mean, Judy is this still on? Yeah. Judy summed it up really well at the very beginning around kind of the amount of trauma that you see in that group of people. The other interesting bit around that is the amount of people that use drugs in a non-problematic way. So the World Health Organization has looked at this, and we know that on a given day, I think the last data that I've read was from 2019, that 280 million people took an illegal drug on one given day. But it's only really about 10% of people that wind up actually having a problem with their drug use. And then within that 10%, the vast majority of people find some natural way out of the difficulty they're experiencing through connection to community, connection to other parts of society, re-entering the workforce. And then what we see is this very, very small slice of people. And I think when we're building programs, it's how we wrap services around that small percentage of people, and that's what the injecting room does so well. My time when I was in Richmond, because I was there before the injecting centre, and I spent a lot of time in that car park. I would go and visit that car park 2 or 3 times a day, responding to overdoses, pulling people out from cars. just the ability to go in and safely and securely, with a degree of kind of like comfort in not worrying if something goes wrong. There's all these other services that are wrapped around that where people can get hepatitis C testing, they can engage with pharmacotherapy, methadone if people want to start on treatment, but also they can have a place where they can just be with other people in their community and feel safe and secure, and I think that's the beauty of these services.
So I just want to put it in perspective. The King's Cross service opened up the medical supervised safe injecting room, opened in 2001. And by 2016 or 2016 figures, they'd seen 16,500 people that year and over 1 million supervised injections.
And nobody died.
And nobody died. Now 70%, and this is the salient point, 70% had not previously accessed any local health service. So you start to see that there's an enormous problem there, but there's no connect between those people and the health services. And that's what we're really here to talk about tonight. So the question is, and bear in mind that Sydney and Melbourne are both 5.1 million people. So if that's the case, what's the lesson for regional Victoria in this? Where does a city the size of, if you take in the Surf Coast and the greater city of Geelong, city of Greater Geelong, you're talking about 300,000 people, growing soon to 400,000. So the question is, what's the best model that you, and this is open to all of you, that you should look
Well, I can answer a little bit of that first, if you want.
Yeah.
If that's right. We've got a growing population as well in terms of what's happening in Geelong. It's not a shrinking population. You've only got to drive down any freeways and see how many houses they're building. When you, having worked in Melbourne, what they have there, which we don't have here, and maybe when we move, so Barwon Health, Drug and Alcohol Services and other services are moving into a purpose-built facility in Murrigal Street, but what you have in places like St Kilda, what you have in North Richmond, what you have in Footscray are services that I suppose they're primary health services for people that use drugs, and we don't have that kind of servicing. We don't have, while Mark probably does all sorts of different other medical work whilst you're at the pharmacotherapy clinic and seeing people predominantly for opioid pharmacotherapies, most treatment is, most of those are just people that are coming in, seeing you for pharmacotherapy and then seeing another doctor for their primary health. And there's a bunch of people that don't have the opportunity to do that. Like you've mentioned, 70% of people at MSIC haven't engaged in primary health. So a primary health service for people that use drugs would be a fantastic start. And we've got Inga in the words. I'm mentioning Inga, who's one of our liver nurses who works in our NSP and provides point of care testing for hepatitis C for the population. We know that when we bring services into the programs that people are accessing with these drugs, they're taken up. When we ask people to go somewhere else, a little bit like my pathology slips that are piling up that I never go and fill. When you send somewhere else for something else, it's difficult for people to engage with. I mean, if you're trying to manage a drug dependency on top of that, life is incredibly complicated. So having services where everything is in one place for people, absolutely.
So two things. Let's throw back to Mark. The first question is, how difficult is it for a GP, you and I being GPs, to actually prescribe in the case of opioid replacement therapy, let alone other drugs?
So I guess when we're talking about opioid replacement therapy, just so everybody's on the page, we're talking about treatment for heroin use and sort of illicitly used but legal opiates such as out-of-control endo use, morphine use, MS-Contin. And there's two very good treatments for that, methadone and buprenorphine. So we know that if you put someone onto methadone who's completely out of control 3 times a day injecting heroin, we know that on average 60% of the people you put on methadone will stop using all illicit heroin within a week to 2 weeks. It's extraordinary. And while they're on methadone, Suboxone, buprenorphine, they won't use any heroin. So it's a fabulously effective treatment. And of the remaining 40%, probably 30-35%, their use will drop from 2 to 3 times a day, so perhaps once a week. Friends come around, you know, might open a bottle of wine, they just like, let's get a few syringes. You know, it's use without lots of harm to it. Maybe illegal, but it's sort of safe, considered use for the most part. And the crime and the sort of disruption of daily life and the poor parenting and the stealing, it all sort of melts away when you're on one of these programs. Now the problem is, there's a little bit of extra training for a doctor to do to prescribe this, and we're talking 1 day. We're not talking 6 months or a 3-month course, we're talking 1 day. But the problem is GPs are so many problems to deal with, so you're dealing with, you know, everything from age, illnesses of the elderly, mental health illnesses, general health issues, just managing good health for people with diet and exercise, women's health problems, that a lot of people go, I can't be bothered with these people who are on drugs. I don't want to see them, I don't want to treat, you know, I don't want to have anything to do with heroin. Unbeknownst to them, they've probably already got some clients who are on heroin in their general practice already. So we somehow need to get the message out that this is easy and rewarding work. And basically, you give someone the drug and you sit and talk to them and listen and just keep seeing them month in, month out. And gradually you develop this, you know, normally you develop a fabulous therapeutic relationship. And people just get better without you actually doing very much at all.
So what brought you into it?
Just an accident, really. So I was working in Corio Community Health Centre, and the older doctor leaned on the younger doctor and said, okay, Sonny, you know, if you don't work here, you better see a couple of our patients. Okay. And just from there, I really enjoyed the work with it. And we do know, like the other mistake people make is they, okay, look, you're on heroin, we just need to give you a detox, you know, let's just get you somewhere, get you off it, and then you'll be fine. But the reality is that the average opiate addiction or dependence is 10 years. The average alcohol dependence is 20 years. They now recognise that the average time for someone with a serious drug dependency problem, from sort of, inverted commas, rock bottom to full recovery, is often in the order of 35 to 40 years. So if you get yourself into real strife in your early 20s, you're likely to be recovered when you're 50 to 60.
And what's the long-term effect of opioid replacement therapy?
So the long-term side effects of methadone and buprenorphine in particular, it does dry the mouth, so you do have to look after teeth much better. But that's just about it. There are no other long-term side effects, really.
And to the whole panel, how much would a regular heroin user be spending a month? I can tell you $1,000 was the quote. And going on to methadone in the old system before the federal government came in to cover it was about $120 a month. And now you can go on to monthly injectable buprenorphine for $7 a month if the GP bulk bills, which we do. So the reality is you've got to ask the question, and this never comes up, where's the money going? Organised crime.
Well, Craig was working out the numbers, weren't you, for the amount of syringes?
Yeah. I mean, and you're right, it's organised crime. That's where the money currently goes. And if you add in syringe programs that we operate in Geelong, provide 500,000 to 750,000 syringes a year across the region. So it's not a small program by any stretch of the imagination. And if we operate on the lower number and assume that we give out 500,000 syringes and then we discard half of them, so we only assume we've given out 250,000, and in each one of those syringes, the smallest quantity of drugs is injected, $50 worth of heroin or methamphetamine. You do 250,000
So the other area that we need to talk to, I'm throwing back to you again, Craig, is the role of allied health and nurses in this area.
Yeah.
Just, can you expand what's going on in the local area in Geelong?
Yeah, so drug and alcohol services itself and the other AOD services in Geelong, because Barwon Health aren't the only provider of drug and alcohol services, they're staffed in a multidisciplinary way. So we have consultant psychiatry and registrars, we have doctors that obviously work and provide pharmacotherapies, we have nurses, psychologists, social workers, occupational therapists, harm reduction staff that is a specialism in and of itself. Most of the services have that similar kind of profile, but one of the things that we've been very good at is partnering with other people, so partnering with sexual health clinics, so we've got good referral pathways, all bringing the services in, our work that we do around delivering Hep C treatment to people. So I think, you know, the solution to lots of this, and it goes back to the question you asked earlier about kind of how do we build better services, it's through partnerships and connecting services that everybody needs, but people that use drugs find very, very difficult to access, mainly driven by stigma. So most people that use drugs have experienced some stigma in their life, if not a lot of stigma in their life. We know through research that people that use drugs are the most stigmatised health population on the planet. They experience more stigma than anybody else. And stigma ultimately leads to poor health outcomes and people dying. So when we move services to where people actually are, and treat people with dignity and respect, and we don't see people, you know, you'll have noticed I use language that's people that use drugs, not drug addicts. We don't pathologise people and see their behaviour first. We see the human first, and we build services around people. That's how services need to be constructed.
It's interesting. I just want to take you through my own case as to why I started doing opioid replacement therapy. I had a patient I knew from Headspace in Corio who came and saw me in a practice I was in at the time, and he came and he said, "Look, do you prescribe methadone?" And I said, no, I don't. And he said, "Good, it's the first afternoon. There's a training course on Saturday. Can you go along and do it?" You go back, and I did it. So,
we need more patients like that. We need
well,
more people doing that.
one of the things about it is, I think there needs to be a bit more pressure put on general practitioners from the patients, not from government, not from organisations. The college won't do it, but from patients and relatives going in and saying, "Look, you know, my son or daughter's in deep shit. Can you help?" And I think that that's the role that the public needs to understand. 9 times out of 10, you'll probably get a rejection, but in that 1%, in that 10%, you might actually get a GP that starts doing it, convinces other people in the practice to do it, and that's a continuous done.
Yeah.
Look, it's great listening to all of this, and just a couple of things. One with the opioid replacement therapy, which is offered at North Richmond Community Health, and the buprenorphine long-acting injectable. I have spoken to people who've been through that program, and it is a game changer. They have it's just a totally different outlook on life, and some people I know who are here know Sadi Milky. Sadi had overdosed twice at the supervised injecting room, and if he'd done that in my laneway, he wouldn't be here anymore. But he's now gone through that program, and he's running a scaffolding business in the city, and his partner, Margot, who we also met in the injecting room, she's now on the same program, and she's back doing a master's in international law. They are just the most amazing couple, and they just totally thank their lives on the injecting room and also that program. I think the other thing too, and I'm talking as a community activist here, how important it is for communities to have these services offered, even if they don't have someone in their life that has an issue with drugs, because it actually has a flow-on effect to the amenity of the community. Now, I know you will all hear how terrible things are in North Richmond. Well, they're not. They're not. I can tell you, I live there, and it's so much better. It's just so much better. We don't have human beings collapsed in our laneways and carports. We don't have ambulances blocking our laneways and access to shops. And we don't have the sound of sirens anymore. It's just a completely changed landscape. So I just want you to understand that what you're hearing is a different narrative to what is the lived experience, and it really does make a difference. And being an activist doesn't mean walking in the streets and having rallies. Being an activist is actually starts with you. You know, they should do something. Well, what about I should do something? And what Tim just said is absolutely right. You should speak to your GP while you're in there getting your heart checked or whatever, and say, hey, do you provide this, you know, program with buprenorphine? Well, I think you should. There is a training on Saturday. Why don't you go along? So do that. Ask the question. I've got someone in my family, a really good friend, who would really benefit, and I know that it works. That's one, number one. And number two, and because I'll hand back here, but I really think it's very important that you all contact your local MP. Now, you can Google Geelong representatives in Parliament, and 9 names have come up. You're very well blessed with politicians down here. Right? You're the luckiest group of people in Victoria. You've got four MPs in the lower house and 5 in the upper house. Wacko. And I'm just wondering, you know how you always say they should do something or politicians are useless? Well, if a politician doesn't know or hear from their constituents that these things are problems, they won't do anything. They can stand hand on heart on the floor of Parliament when these things are being debated and say, well, my community's not telling me this. And it's about time you did. And do it respectfully, but do it with stories. They can get all the data. Don't bore them with data. Say, I live next door to somebody who blah, 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 and it's all anonymous, but this is my lived experience of Corio or Belmont or, you know, wherever. And not just do it once, but do it again in 2 months. Put it on your phone and I'll ring that, you know, that person back. Because unless we do, we'll get nothing. We'll get nothing.
Thank you. I'm just about to hand over to questions, but just a couple of phone numbers. The take-home naloxone program has a number, and we'll give this out later if anyone wants to take it down, but it's 1800 196 850. And then all access for drug and alcohol services in Geelong goes through one number. That's 1300 094 187. And there are 6 rehabilitation services and drug and alcohol services in the Geelong region. So it's not from the Geelong Clinic, Bowen Health Jigsaw, Hayter Clinic in St Albans Park, Habitat Therapeutics in Newcombe, Salvation Army Detox Unit in Corio, and Stepping Up Geelong that does outpatient detox. So we do have facilities here. I'm going to throw it over to the audience now to ask questions for the next 15 minutes, and there'll be a roving microphone, so if you just want to put up your hand to ask a question, we'll take it from there. And by the way, just in case you hadn't picked it up, hepatitis C is particularly transmitted by sharing needles. Any questions?
I've got a question for Mark. I'm just wondering, is some of the reluctance for GPs to take on the role of being a prescriber the fact that there's pressure from other doctors in the practice not to perhaps have addicted patients in their practice?
So there have been a few practices around the place that have deliberately not wanted someone to sit in the waiting room who might have a drug dependency issue. Though I know some of the clients of some of those practices, and they are sitting in those rooms, they don't know they have got a dependency issue with the doctors, so they don't say anything because they know they'll get discriminated against. So yes, I think there is some pressure sometimes from high to low to what sort of clientele they think they want. Yeah, which is very interesting.
Doesn't mean you can't ask. And I think the more you ask, the more you'll get a response. As I said, if you're only looking at 10% positive response, that's actually a lot.
Well, I suppose the important thing, James, thanks for your question, is that supervised injecting facilities should be open where there is already a honeypot. So one of the furphies that's spread in the media is if you open an injecting room, it will create a honeypot, which is a honeypot is just basically a drug market that's been in existence for some time. And so people who are, like we were in Richmond and Abbotsford, where I live, we knew that we were living in a drug honeypot. It was quite clear. So it was a relief to have that support, to have people acknowledge that you have that issue. And that included some of the traders. So I can only talk about the traders that lived around there. And it wasn't just residents who were calling O and staying with people while they were overdosed. I mean, young baristas along Victoria Street, students who would get holiday jobs there, they were also dealing with this. And a lot of the people that ran the businesses, not the shop owners, so the landlords are a different kettle of fish, but the actual traders thought it was great because they had their shop access blocked by ambulances. They had people collapsed outside their shop. So I don't know the Geelong drug market, and there may well be a place in the city of Geelong, and somebody did mention the Mall, but I don't know about that area. But if there is a drug honeypot, there will be relief for people in those areas if it's a well-managed and well-resourced facility. So, what we've heard in the city of Melbourne too, we don't want to open up an injector room because it'll end up like North Richmond. Well, bring it on, I say. I think it's been great what's happened in North Richmond. And people have got somewhere to go, as we've all been talking about. And it's just lowering the barrier of entry to people who really need that support. And they don't get it in my laneway or anybody else's laneway. So just find out where the issues, where the people are, and talk honestly. And people won't tell you the truth because they don't want to be told by the owner of the shop, well, we're not, you've got to do what we want. But people who are in drug honeypots know that they will need relief. And the same in De Grave Street, the same thing there. There'll be people there that will say, the young women and men that come in to open up those shops at 6 o'clock in the morning and probably find somebody collapsed at the doorstop. They would want them to be somewhere else in care, not there. So, yeah, I think we're not being honest about this.
Just to get a perspective from the Geelong area, is there a demand for a safe injecting facility here?
Well, there isn't. I think one of the misconceptions is that when we think about supervised injecting facilities or drug consumption rooms, we think about them in this one way. We think about EMSA and MSIC, the injecting facility in King's Cross, and we think about the one in North Richmond. We think about these big purpose-built facilities with multiple booths that are situated in places where there is lots of people using drugs. And then when you come to a regional town like this where the drugs market is far more spread out, and we know from overdose data that if you go back over time, lots of overdoses took place in people's residences or people travel to another person's residence. There was a shift in that in 2016, 2017, and we saw more people fatally overdosing on the street, and we saw more of that happening in the CBD. Now, that doesn't necessarily mean that we need an injecting facility in the CBD. What I actually think we need to think about is when you've got a spread out, diverse drugs market, and you've got people using drugs in lots of different parts of the community, the smaller services where people are already going to collect injection equipment, for instance, if someone can collect injection equipment and then have somewhere safe where they can inject that, you don't necessarily need to build these huge facilities that have a huge impact on local amenity. You can look at more unique ways of solving the problem. So that would be the first thing that I would say about it. And if you, with the exception of North Richmond, anywhere else that you go in Victoria to collect sterile injection equipment to use drugs, you will be told once you've collected them to leave. Lots of people will try and go to the bathroom, so they've got somewhere safe where they can use, somewhere they can not be discovered, not be found, not be rushed, where they've got access to water, where they can wash their hands, where they can wash their arms, where they can be clean, it's well lit, and they can go and do that really risky behaviour somewhere else. And so when we think about how we design services in the future and how we start designing services now, I think that needs to be something that we factor into how harm reduction services are built. We don't always have to think about these large purpose-built facilities, because drug markets are different all over the place, and they change constantly as well. Drug markets change constantly. We've seen the same similar changes here. So I wouldn't say 5 years ago, if they asked the question, I said, well, there's no need for an injecting facility here. Now I would say we need to think really, really carefully about how we build injecting facilities where we're supplying the equipment for people to use.
Hi, I'm actually paying for a second injecting room at the moment, and I do believe that we do need them, especially where they are giving them out, where there's no duty of care. Like, I come from Northern Cryo, I see it daily in our area. Like, I've lived there 20 odd years, and it's changed dramatically over the last 8. Kids are confronted with it. I've got footage of a safe house, like a squad house that's 50 metres away from Barwon Health, where they all go, and these kids come off the street into it. So the problem is here, and it is, you know, the locals won't use the toilets, the public toilets in the area. The mic keeps going off, I think. It's already here, and the public are already confronted with it. And there's also the ice, where you see people very well in the streets all the time, which is frightening to some people, a lot of people, because you're not quite sure what is going to be the next action, you know. And I think it's true too that Whittington's got a big problem. Maybe everywhere that there's a where there's a needle exchange, there needs to be a safe injecting room. Like, you can't give needles to, like, the first step of NA is our life is unmanageable. So, like, they're going to go to wherever it is. And if that's going to be a locked toilet in a Barwon Health Centre, that's going to be where it is.
Not always safe.
Not always safe. No. You know? Signs on the wall is not going to stop it. Nothing's going to stop it. They're going to use it as soon as they get it. And there's no changing that. It's the way an addictive mind works. That we need them. And it's only going to get worse. It's not going to get better. And I'm scared that Australia follows America in the way of thinking, instead of thinking more progressively, like Canada. You know, where Canada and Australia are the highest, with the highest overdose rates. Canada's got 40 rooms. Australia's got 2, and there's a fuss about them. They've just legalised in Australian Capital Territory to carry it. So if they're going to legalise it there, they're going to legalise it not legalise, decriminalise, sorry. You know, what happens if they decriminalise it down here?
Thank you, Debbie Harvey, and I haven't met you, but thank you for the work that you've done since the sad death of Jai, your son. So my condolences to you and your family and his friends. And yes, I hear you and I agree, and I think it's also what Craig was saying. You don't have to have great big facilities. They can be discrete facilities, and it just seems crazy that we do hand out clean syringes and then people have to leave the premises to use drugs in unsafe places. So, and I think the other thing you touched on, and I think Mark did as well, fentanyl's causing huge strife in Canada and the US, and we are on the precipice of it coming here, and I think we're very underprepared, and the demands on where you're working.
It's already been found on the shores, they've already got it at the border.
So I think we need a much better strategic and courageous view from our governments to look at this issue and stop pretending it's not, they don't work, and the media have a role to play in this too. Some honesty around a narrative of people's lives being saved and changed.
Yes.
People's lives can be changed.
It's bigger than a road toll. We get road toll accidents, but we don't get any education to our children of how many deaths from people overdosing. You know.
Thanks, Debbie. Any other questions?
I've just got a
question about the Richmond facility. Does it enjoy support and sort of championed by one of the major metro hospitals, or is it a...
Well, it has. It's been doing a lot of work in the hepatitis C study and management of it, which has been very successful with St Vincent's Hospital. So that's
With St.
yes, so that's St Vincent's has been. They've also had connections with the Alfred as well in various for various aspects. In fact, one of their anaesthetists was sort of co-managing it for a while, but yeah, definitely.
Because as I say, I'm not familiar with the Richmond facility, but I'm really familiar with the Sydney one.
Yes.
And it has such a great relationship and great support from St Vincent's, and it really champions it. It puts the stats out. The residents know how effective it is. They know how much it saves in dollars. You know, that old saving the cents stuff. Like, you know, the call-outs, all the things we know, not only, you know, used equipment, etc., but St Vincent's is such a champion of it, and in mainstream forums, so in local magazines and things, and I think that is really effective, and that bipartisan support too, which I don't know, is that supported by like major political parties in Victoria, or is it not the case?
Oh no.
Yeah, and I think that might be. And also in mainstream health, because these guys work in, you know, that very precious area of, you know, mental health, drugs, alcohol, and not much. It's also GP world, but in the mainstream public health service, it's seen if you are moved by it and want to be sort of active in that area, it's basically, if you look at like a little bit odd, and you get called passionate. And it's that, oh, we appreciate your passion. You're not taken very seriously. So that's just a little bit of my own experience in, so, you know, anything you mention around environment, people who inject drugs, trying to make sort of things better for the vulnerable, we appreciate your passion, but so...
Yeah, passion's a bit of a funny word, isn't it?
Yeah, well,
people romanticising my anger is actually what's really happening. These people are romanticising the anger that I have that we don't have proper political support.
Like you're a little unhinged, you know, you're a little bit emotional or hormonal or something, but no, you can be really keen to be active, to try and affect change, and I think that's an issue that I've experienced in this area.
So the interesting point about that is discussing with your GPs, discussing with your local members of parliament. The more pressure that comes on, hopefully it can change that sort of attitude. This is a community problem. It's an international problem. And if you think that organised crime stops at the skate park, it's also in parliament. Any other questions? Yes, and this will be the last one.
I was just keen to get the prescribers of the opioid withdrawal products opinion on whether there should be a push for not formally needing that training for GPs and other doctors. Other doctors are expected to understand and know what the other medications they're prescribing, so patients can ask that of them. Should we be removing that barrier? So
technically, the barrier was removed. Any GP can take up to 5 of these patients, and that law came in, I think, about 3 or 4 years ago. It still stands, but the MATOD training is excellent, and it's, as Mark said, I think it's even half a day. It's so informative, and it gives you a model to work with. This happens in many different formats, clozapine, Tylenol, Tretium, all that sort of stuff. So.
Yeah, so one of the drugs is very safe in overdose, the buprenorphine drug, and any GP is allowed to prescribe up to 5 patients without any training, and there are services in Geelong where you can phone a central number for advice on how to do convincing your colleagues to do it is tricky, actually. And we have a service in Victoria called the DACAS, which stands for the Drug and Alcohol Specialist something service. But anyway, you bring them up and you get a specialist in addiction medicine on the phone within an hour or two to tell you exactly how to prescribe these drugs if you're not sure, how to manage a detox from marijuana, how to manage a detox from methamphetamine. Yeah, so it is there, and you're right. You know, they have removed the barriers, and it has made a difference to some extent. So it's allowed me to pressure some of the clinicians I work with a lot and get them to take on a few clients. Because if every doctor took on, 5 patients, we wouldn't have a shortage of places in Geelong, so the Geelong region.
I think the biggest challenge beyond the GP's skill, I suppose, in prescribing the medications is humanising the population. I think what we don't see enough of, and the biggest struggle is the misconception that people that use drugs that are in some way to be feared, or that they're difficult or dangerous, or whatever the label is that's attached to people that use drugs. I think that's the biggest challenge that we've got in terms of changing the tide from GP prescribing, is to humanise the people. And I think that's the role that people here have probably got, is that when you do speak to your GPs, I think one of the challenges is being open and changing the narrative and being open and candid about our own drug use. I think that because there's so much stigma about it, people aren't open and transparent about their own drug use. And so there's always this shroud of mystery around it, and this degree of kind of fear that the people who use drugs, they're somehow different to everybody else, and they're not. So I think that's the biggest challenge that we've got. If we want to get GPs to write prescriptions, they need to first of all see the people in front of them as people and not as this different population. That's the biggest challenge I think we've got. Because most of the GPs, if they got through medical school, they're pretty smart, they can study hard. They're only going to do what they study. Well, some of them study hard. And they've got Google. But they
sat in front of the class at
that's
school.
right. But they only need to do one day. And I don't think that's the challenge, because lots of GPs, I can't remember what the data is, but there's lots of people that have got the ability to prescribe that don't prescribe. They've done the training, but they don't go on to prescribe. So that's the challenge that we've got.
It's overcoming that stigma within the practice, and that's really what this night's about.
Yeah.
That's when Judy came to talk.
It is confronting, isn't it? If you've been a nice little middle class boy or girl, brought up in a nice middle class school, and then you go through medical school with a lot of other nice middle class people that studied well and sat in front of the class, and then suddenly you're confronted with someone that's injecting 3 times a day. And you go,
And you've got a Bob Willow.
Especially if it's the doctor next door.
Right. You can see that this is now starting to wind down. Yes, Robert.
Can I just firstly thank you for putting this on? This is terrific. Well done. It's lovely to see some former colleagues from Melbourne Health and Judy. Well done on a great campaign. Just a couple of observations. I think firstly language matters, and I don't think we should talk about them as supervised injecting centres anymore. I think we should describe them as overdose prevention services, because, firstly, there was a study in the US that showed that when you start talking to people about overdose prevention, you actually shift the way people think about what we're doing. We're not really in there to supervise someone and make sure they get good drugs. We're in there to, these services exist to stop people from dying. It's an overdose prevention service. I think that's really important. Can you all hear me? So on that, I think that's important. I think on the medical profession and health more generally, if you want to get treated really badly as a drug user, go into a hospital where often a doctor will assume that your pain is coming from drug-seeking behaviour because you want to get your hands on the good stuff, or the judgment you get from the middle-class person who went through medical school and thinks this is a problem that happens to other people, but actually it's a problem that happens right across the community. So stigma is one of the greatest challenges we've got. And why would people come forward when they're admitting to doing something that's illegal, that's going to jeopardise their job prospects, that's going to lead to potentially repercussions? So one of the benefits of actually removing criminal penalties for personal use is you start to have a different conversation around how people use drugs. I think that's really important. And I suppose finally, just a real kick up the bum to my medical colleagues.
Not us.
Not you guys, but the reality is that it should be considered totally unacceptable to not offer this service to people. Can you imagine someone coming in who's overweight, who has diabetes, type 2 diabetes, and the doctor's sitting there saying, I'm not going to prescribe you your diabetes medication or insulin because you're engaging in a behaviour that's contributing to your illness. No, we wouldn't accept it. It should be unacceptable. And it should be unacceptable that what is the most effective treatment for someone who's opioid dependent, and it's not hard. Like, sorry, the prescription of methadone and buprenorphine is bog standard, basic, easy medicine. As someone who was a prescriber, it's not difficult, and doctors don't do it because, well, they don't prescribe not because it's difficult, they do it because they themselves are perpetuating the stigma that exists within the general community, and they are members of the community, and they are subject to the same human frailties that many people have. It's one of the few areas where you can pick up a newspaper and hear people referred to as junkies. As someone who's been working on the supervised injecting overdose prevention service in the city, and watching the way that debate has played out publicly, it's been appalling. So we've got to, I think Judy's right, get on to your politicians. I think you're right, hassle the doctors, but the college should be regulating this, and it shouldn't be a choice left to doctors. And ultimately, I think as a community, it's wonderful that you're all here tonight. You've got to organise, and we do need a model where people can walk in, get their clean needles, and not be forced to go into a lane way around the corner, inject, and potentially die as a result of a policy that could be changed very, very quickly.
And the interesting thing is, as Craig pointed out, that model we already have disseminated services around the community, and the provision for injecting up areas could be introduced, but it needs a bit of pressure. I'm going to need to wind up. Thanks for that, because it was a really salient point, serious point you made. I want to thank Judy.
Sorry, Tim, it's probably just worth mentioning that Richard did actually work in a methadone and buprenorphine clinic for a couple of years before. He is Jesus, yes. So I was just going to say that. Thanks, Tim.
Coordination. Okay, so Judy, Mark, Craig, we really appreciate your interesting and insightful discussion tonight. It was really useful. It was pretty much open slather. We appreciate that. The audience, we really appreciate you coming along tonight. It's been really important to sort of make this a community effort and maybe the starting point for going forward. As we've seen tonight, the role of community alcohol and drug and alcohol services is crucial to meeting demand for people who use drugs. The network includes GPs, in our case, Melbourne Health Drug and Alcohol Services, detox services, counsellors, and of course the families and friends who tend to get forgotten about in this whole process, who support those people and provide accommodation and everything else for people who run amok with this condition. Now, Judy's brought copies of You Talk, We Die, which is a really informative read because it tells you, one, how hard it is to set these services up, but two, how you can coordinate within a community and get things moving. And it's a really good case study. So please take the opportunity to purchase it. down the back, John, Judy's husband, he's got the white cap on, just in case he needed any identification. And You Talk, We Die is also available to borrow at the Geelong Regional Libraries in hardback or audio format. And thank everyone for coming tonight. And on behalf of the Geelong Regional Libraries, we really appreciate the fact that we've got this fantastic facility that we can use, and it was really not that hard to get on board. So we really appreciate it.